Okay, we'll get started now. Thank you all for coming to the initiation of our 2015-16 year of medical grand rounds. You all have purchased a season ticket, whether you know it or not, so you're welcome to show up every Tuesday afternoon. Something that I want to talk about today is something that's near and dear to my heart. Being an oncologist, I guess I get my share of having to tell people things they don't want to hear. And I can tell you that through the years, I've fumbled many times in one home feeling terrible, that I just didn't do a good job. So I made it a commitment to learn how to do it better. And I'm going to be referencing some people: Anthony Bach, Robert Buckman, Robert Arnold, Walter Bale, people that I have mentored or let them mentor me. And so the skills that some of you might have seen me use and the skills I'm going to be talking about are skills that I've actively learned from them. None of this comes natural. What we're going to do is try to recognize the normal physiology and anatomy of difficult communication. Now you might say, what do I mean by physiology and anatomy? Well, we're doctors and we like to think about anatomy and physiology. So I'm going to break communication into its anatomic and physiologic layers and show why we have difficulty. And then I'm going to show how empathy can soothe those difficulties when we're having difficult conversations. And then we'll learn finally how to use the SPIKES protocol for the empathic delivery of bad news. I have no conflicts of interest, but that does not mean I have no conflicts. I have a wife and 5 daughters, and believe me, there have been lots of conflicts in my house. And actually, some of the skills that I've learned in navigating conflicts have not just come from the patient's bedside, but from negotiating with daughters that are fighting with each other and fighting with me, etc. And the reason I tell you that is these are skills that might not feel comfortable to you if you haven't used them. And if the first time you have to use them is at the bedside, it's not going to come natural. So practice, when we get to the SPIKES protocol, practice it with even family members. If you have to tell a family member you're not coming home for Thanksgiving, use the SPIKES protocol. If you have to tell a neighbor that your dog got into their yard and tore up the rose garden, use the SPIKES protocol. Get used to it so that it becomes natural. As a matter of fact, it has become so natural to me that my kids now call me out on it. If we've got an issue going on and I start using the SPIKES protocol, they go, "Dad, I'm not one of your patients, cut it out." So, but that means it should become that familiar to you that it becomes your automatic communication mode. Now, what's the difference between information dumping and communication? And I'd mentioned Anthony Bach. This comes from his book, Mastering Communication. He tells a little story about himself. He says a young patient was quietly sobbing as she told her doctors how unfair it was for her cancer to have come back. The fellow who was leading the conversation tried to reassure her and started listing therapeutic options that were available. Well, we've got tamoxifen, we've got this, we've got that. But she began to sob louder. Somehow this was not helping her. So Dr. Bach, the attending, stepped up to the plate and he said, "You're right, and you're being very polite. This really sucks." Now the fellow was surprised, 1, that he said that, and 2, he even used the word sucked. But the patient smiled. Now, what common but misguided assumptions had the fellow made? And this is the audience participation part. What assumptions had the fellow made that didn't resolve the problem? Any ideas? None? Okay. She felt that she needed to stick to the facts. She was going to talk about this situation and what treatments are available. She needs to maintain an objective distance. The patient just expressed a very significant emotion. She's crying. That's about as emotional as you can get, and yet I need to keep my objective distance and just keep information dumping. She thought that if she provided more information about various treatment options, that would obviously make the patient feel much better. And obviously the patient must have good coping skills, so if I just let her know the path ahead of her, she'll be just fine. Well, those were all misguided. And what did Dr. Bach do that changed the trajectory of the conversation? Remember, he got her to smile. Well, first of all, he made none of the fellows' assumptions, none of them. But he provided an empathic response that did a few things. It acknowledged her emotions. He let her know, I see that you're upset and I get it. He validated those emotions by saying, you're right, and you're being too polite. He used language that was appropriate for her. She was a young woman. So he might not have said it sucks to an 86-year-old man, but to a young 28-year-old woman, he felt comfortable saying, yeah, this really sucks, because that's what she's going to say when she goes home and tells her friends. And doing all of those things allowed him to connect with his patient in a way that the fellow failed to. So he provided patient-centered care, but his fellow was providing disease-centered care. She was all about the disease, he was all about the patient. So we hear a lot about patient-centered care, don't we? Well, what is it? Well, the predominant goal of patient-physician relationship is focused on understanding not only the disease and its treatment, but its impact on the patient. You might tell me that I have a curable disease, but if I have to be traveling back and forth to Shreveport for treatment and I don't have transportation, it might not be so treatable for me. So my level of suffering may not be what you predict because you don't really know how I'm impacted by the diagnosis. Patient-centered care, we bother to learn that information. The agenda of care then includes the viewpoint of the patient, their opinions, their goals. Some of you have heard me say before, I do not like when a doctor says, you have failed this treatment, we need to start that treatment. Nobody needs to start anything. Your job is to see what they want to do and then pick the therapy that's best for their goals. You want them to participate in shared decision making where they really come to the table and weigh what you've got to give them and make a choice that's right for them. Your job is to be a tour guide, not a pilot. Your job isn't to get into the cockpit of the plane and fly them where you want them to go. It's to try to figure out where they want to go and get them there the safest way possible. So support is tailored to the patient's needs in a way that fosters that shared decision making. So this is what patient-centered care is all about. But it has an enemy. It's called the hidden curriculum, and most of you know about the hidden curriculum. It's an unintended consequence of education. We teach things that we want to teach, and things that we do but don't teach still get taught. And that's the unintended curriculum that we talk about in medical education all the time. So for example, us attendings, we often quiz our trainees about the labs, scans, and treatments that they're considering. Why are you ordering this test? Why not that test? Did you get an MRI or a CAT scan? Why did you do that? But less often do we pay attention to how they explain that information to their patients. How often do we actually give our trainees feedback on how they communicated that information back to their patients? So the hidden, but very well implied message is that communication's a nice touch, but it's expendable as long as you get to the right diagnosis and offer the right treatment. That is the hidden message. None of us would say that that's true, but that's the message that we deliver many of our students and residents. And there are studies that show that the vicarious empathy, when they do studies to measure your empathy, from first year medical school to last day of medical school goes down very dramatically. We beat the empathy out of our trainees. We teach them Let's not go with that emotional stuff or the communication stuff. We got to get to the right diagnosis. And that's one of the problems with evidence-based medicine. Evidence-based medicine is great for telling you what's the best evidence for a given goal. But what do we forget? Not all patients have the same goals. So evidence-based medicine might say that this is the best treatment for my disease. Ivox might be the best antibiotic, but if I can't afford it, it's the worst antibiotic for me because I'm not going to take it. So evidence-based medicine, you'll hear people quoting without saying, how does it tie into my patient? And that's where you get back to patient-centered care, is when you kind of let the hidden curriculum go to the wayside. Now, the foundational tool of patient-centered care is empathic communication. You need that to help patients set goals, because you're going to be oftentimes having to choose difficult conversations. Do you want to go to the ICU? Do you want to be intubated? Do you want to go home? Do you want to be comfortable? These are things that you're going to have these discussions knowing that emotions are going to be evoked. Obviously, when you break bad news, you're going to need empathic communication. When you discuss a serious prognosis, you're going to need it. When you discuss code status and advanced directives, you'll definitely need it. And absolutely, when you transition to end-of-life care so that the patient's not feeling abandoned, you'll have to use empathic communication. But there's the problem, is actually this showed up in USA Today a few years ago. It was based on an Archives of Internal Medicine article, but it made it to the national news that doctors do not show very much empathy. This study, they looked at, they had transcripts of recordings where doctors talk to their patients, and they looked for any empathic opportunity. And an empathic opportunity was when a patient voiced or demonstrated physically a very clear emotion. I am scared, I am angry, I am pissed, I don't understand what the hell's going on. And all but 39 times did the doctor ignore it. Sometimes the doctors even kind of looked at their watch and said, "Are you done now? May I go on?" That's how the doctors dealt. So only 10% of the time did the doctor even acknowledge the emotion. And I love this line, all people go to medical school because they want to help people. I guarantee you that everybody in this room, when you applied to medical school and you were being interviewed, why do you want to be a doctor? All of you use some version of that line. I want to help people. And yet, sometimes something as simple as, boy, this must be really scary for you, is one of the best things you can do to help somebody feel better, just to let them know that you connect, that you get it. But us doctors are not very empathic. Now, you might say, well, it's proved to me that I need to be. Okay, well, I'm going to. I'm going to give you some empiric evidence that empathic communication isn't just a nice touch, it's absolutely essential. And that's by getting into the anatomy and physiology of communication. All right, a woman says to her husband, "You sure spent a lot of time talking to that pretty young girl at the party last night." And he responds, "No, I don't think I spent any more time talking to her than I did anybody else." "Well, then why don't you just have your new friend make dinner for you tonight?" What went wrong with that conversation? Well, you need to know that there are layers, like anatomic layers. Communication is both cognitive, and that's frontal lobe driven, where we filter and censor information. It's cognitive. Is it going to rain today? Yes or no? Emotional is kind of generated through the limbic system in the amygdala. Is it going to rain today? That means I have a vested interest. Maybe I'm a farmer and all my crops are dying, or maybe I've got a wedding planned for this afternoon and it's an outdoor wedding and I don't have an indoor venue lined up. So, you know, if you just see the statement written, "Is it going to rain today?" you don't know if it's cognitive or emotional. But when you watch somebody and interact, you should be able to tell. And those are the two layers. Now the problem is, she was communicating at this layer, wasn't she? She's doing this.
It's flipping on and off.
So she's, I don't know what,
Is it on?
I think the battery All right, well, I'll try to, why don't some of you make it closer? All right, so anyway, she's standing like this. Leaning back, larger part of the chest, walking her foot. She says, you spent a lot of time talking to that pretty girl before that. Was she just giving you cognitive information? No, she's providing emotional information. She is jealous, she is unhappy. You don't get this fit, you're going to sleep in the garage. But he responded, come to me. Actually, I spent 4 minutes talking to her, and I spent 2 minutes talking to everybody else. He's trying to deflect her emotion by giving some facts, and that's not working. So what are the results of mismatched layers of communication? Well, exactly what you experienced. So maybe we should just have to be friends. So the result of this mismatch is she's still pissed. So why don't you just have your new friend make dinner for you, doctor? So that did not go well, but it's going to escalate because he hasn't learned his lesson. Now his amygdala is firing, he's angry, and he noticed her attitude. You know, when you get like this, you're just like your mother. Oops. What do you think's going to happen tomorrow morning at breakfast? They've kissed and made up, and she's going to say, honey, last night, when we were having our little argument, you made that comment that I'm just like my mother. What did you mean? Well, you know, I was just angry. Oh, honey, I know you were angry, but what did you mean I'm just like my mother? I was just saying, what do you mean I'm just like my mother? He's sleeping in the garage, okay? So now what happened to his ability to censor his thoughts before expressing them? As those words were coming out of his mouth, he knew that was an oops. And yet he couldn't stop them. Now we've all been taught by our mothers to count to 10 when we're emotional before we speak. Why? That's going to get into the physiology of communication. So what part of the brain censors, filters, and files outgoing information? It's your frontal lobe. And what part deals with emotional content? It's your amygdala. And I would recommend everybody get this book. It's a short book. You should definitely read it. Emotional Intelligence, Why It Can Matter More Than IQ by Daniel Goleman. He describes why all of us in this room probably know somebody who's much smarter than us, but is stacking boxes at Walmart because they just couldn't function in society. They just don't have emotional intelligence. They have intelligence, cognitive intelligence, but not emotional intelligence. So he coined the word, when you hear the word amygdala hijacking, that's Daniel Goleman's. Well, we know that this is the physiology. This is the way God or Mother Nature, whoever you want to believe made you, designed you, that higher level frontal lobe reasoning has to give way to the more primitive amygdala. That's your fight or flight response. You don't have time to think through your options. If a tiger is chasing you, you don't have time to think about, oh, am I going to get my new shoes dirty if I run through the creek? Your job is to get the hell out of there quickly. So the emotional brain, we do know this. This is physiologic. The emotional brain processes information milliseconds earlier than the rational brain, so it gets to the cortex before the cognitive frontal lobe. And that leads sometimes to irrational and destructive choices, and that's why Mom told you to count to 10, because she wanted your frontal lobe to catch up with your amygdala. That's why when you're angry, you don't hit the send button when you type an email. You let it cool off for a while. We've all been there. If you're smart enough to not hit the send button, and you come back 5 minutes later and read it, and you go, oh boy, am I glad I didn't send that. Filtering and censoring become secondary concerns when your amygdala hijacks your brain. So when you're dealing with extreme emotions, which we're going to when we talk to our patients about things that they don't want to hear, we can information dump all we want, but their intake of this new information is muddled. We've all been in the situation where we thought we've done a splendid job explaining what the CAT scan showed and what it means and what our new therapies are going to mean or be. And we get done, we think we're done, and the patient says, Dr. Marion, what did that CAT scan show? And I realized I've just talked for 15 minutes. They didn't even hear me because they were stuck in an emotional mode where their frontal lobe was paralyzed by the amygdala. They didn't hear anything I said about what this means and what the next step's going to be. So their ability to generate appropriate responses, including decision making, becomes subject to error. And that's why if we have to let, when people are headed towards a cliff, you kind of need to let them know early. Many of us have, and I think we're going to do is a noon conference Wednesday or Thursday on this where you're going to have to use these skills. We're going to talk about having DNR conferences. That's why if you talk to somebody right before they're about to die and say, do you want everything done? They're going to say yes. Their fight or flight response is kicked in. And we walk away saying, oh, they're not being realistic. Well, maybe they needed some time for their amygdala to quiet down so the frontal lobe can process what you're saying. That's why when you sense somebody headed towards the cliff, you need to start having conversations early. So psychophysiology suggests, if I've convinced you, that because of the amygdala, you have to address the emotional layers. You have to get that amygdala to cool off before you address cognitive levels. I think this girl has realized there ain't nothing she's going to say to make that girl say, oh, I see your point. Because this girl is really, really angry. She's got to get her calmed down first before she's going to make her argument. So we know that our job is to get the frontal lobe to take control of the brain again. And so to do that, we have to dial down the emotions, and that's where empathic communication becomes the skill set you need to use. So what is empathic communication? Well, empathy is the ability, pathos is emotion, and EM means to feel into. So I'm getting into your emotions. I'm understanding your situation, your perspective, and your feelings. And I have to let you know I get it. It's not just enough for me to think to myself, oh, he's angry. I need to say, I can see that you're angry. They need to know that I see that. That allows us to connect with the patient and lies at the heart of medical practice. This is another good paper that some of you might want to read. Let me see if I have this right. Words that help build empathy. Clinical empathy often entails responding to the patient's either expressed or suggested emotions. Sometimes you're not sure what the emotion is and you're not sure why it is. I might have just told a woman that her breast cancer came back. She starts crying, and I assume her emotion is that she's afraid to die. And I start talking about, oh, I got therapy that can buy you 10 years, and you're already 85 years old. You'll die of something else. But she starts crying louder because I made an assumption that her emotion was based on the fact that she thought she was going to die. But maybe her emotion was based on something else, like maybe her granddaughter is getting married in 2 weeks and she didn't want to have to go home and rain on her granddaughter's parade by bringing bad news home. So sometimes the presence of a strong emotion is obvious, but we're not sure what the nature of that emotion is, and that's where you have to ask. You can say, can you tell me more about what you're feeling? Or I can sense this is really upsetting you. Can you tell me more? We're going to talk a lot about ask, tell, ask. It's probably the best foundational tool in communication you have. Ask before you speak, and then ask again to make sure you got it right. So after perceiving back, so I say, tell me what's going on, and she goes, Dr. Marion, I knew I'm going to die one day. I'm 85 years old. I'm not worried about that, but I'm worried about my granddaughter and my daughter. They're all excited. Everybody's so happy about this wedding coming up, and now I have to go home and tell them my cancer's back. That's going to upset everybody. So then I need to reflect back what I've just heard. So I'll say, so if I'm hearing you right, what really bothers you about your illness is the effect it's having on your family. Am I correct? Or do I have this right? Or did I miss anything? Because sometimes she might say, well, it's not so much my family, it's really my daughter, or something else that allows you to clarify it. So this request for and respectful acceptance of the patient's correction is a powerful way of letting the patient know you really care. I really want to know what's going on in your head, and I really am trying to connect with you. And nurse is generated by, some of you came to our ethics conference a couple of years ago. Robert Arnold was our guest speaker. He's from the University of Pittsburgh. And he helped generate this nurse name, understand, respect, support, and explore. So when you sense an emotion, whether the patient says, I'm angry, or the patient gets up and starts pacing, or the patient doesn't make eye contact with you, something where you got the idea this patient's upset, you try to name the emotion the best you can. If you don't know, you do what we did in the last slide. You say, can you tell me what's going on? But once you kind of think you know, you say, it sounds as if this is becoming frustrating for you. And then you got to normalize it, let them know you understand it, and that it's okay. So you can say, this must be really difficult for you and your family, having to go through all of this, especially at the time of the wedding. And then to respect it. Say, you know what, I get it. It's very reasonable for you to feel this way. I would feel this way too. I can't imagine anybody who would like hearing what I just said. It lets the patient know that you're kind of trying to get into their place with them. That it's not me versus you, it's us. When you do these things, you're making it us statements instead of this is your problem, you go home and deal with it. And then support. I'm going to do the best I can to help you through this difficult time. And then explore, tell me more about what has you so concerned. If you can remember to name, show understanding, show respect for, show support, and explore, you're going to do a wonderful job generating empathic responses. And this is going to tie in even when you have conflict, which we'll see in a little bit. So words are nice, but in the following cartoon you're going to find that words just aren't enough. So it's nice to say I feel your pain, but that's not enough. It's more than words, it involves your presence. It's your body language. Are you making eye contact? Are you sitting down? Is your posture open or are your arms across your chest? Am I leaning into you, which means I really care about what you're saying, or am I folding back because I want to get as far away from you as I can? Am I actively listening? Am I nodding? If you're talking about your misery, am I shaking my head going, Am I gently touching when appropriate? If you start tearing up, is it appropriate for me to touch you? You'll know when it is. You'll know your patient well enough if you can put your hand on their hand. If they start crying, is there anything more empathic than handing somebody the facial tissue? And that's why those of you who've worked with me on the oncology unit know I get kind of fussy with the nurses when we make morning rounds if there's not a box of Kleenex in every room, at every table. Because too many times we will start having a discussion, the patient starts crying, and then you recognize there are no Kleenex and you're having to hand the patient paper towels or their bed sheets. So always this is something you can help me with. Nag your nurses, say when you make morning rounds, you want to see a box of Kleenex at every patient's table, because when they start crying, it's one of the most important empathic communicators you can do is pick up a Kleenex and hand it to the patient. That's another nonverbal way of saying I get it. So what are the common potholes on the road to communication? One of the biggest ones, and the reason I'm talking about these two potholes, are because these are things we address in the Spikes protocol of breaking bad news. Not knowing what the patient understands or has been told is a major issue. So what diagnoses are being considered? The surgeon calls me and says, I'm sending this woman who's got this inflammatory mass that looks like neglected breast cancer. This is horrible, this is terrible. But he tells her, well, there could be some infection there. I'm going to send you to the surgeon and get this biopsied. And the surgeon goes, yeah, I agree with Dr. Marion, this looks like a terrible cancer. And this is the first she's hearing of that. So does she know what diagnosis is being considered? Some of you know I've sent, I think Adam, I sent the paper in Dr. Greenberg about, it was in the New England Journal just a few months ago, about a study at Dana-Farber, published in the New England Journal. Good journal, good school. 82% of patients with incurable metastatic lung cancer and 69% of patients with incurable metastatic colon cancer were surveyed, and they said they were being treated with curative intent. They talked to the doctors, and the doctor said, no, I never said that. It's palliative. Well, somehow the communication didn't occur. This is a good medical school and a good journal. And we see that all the time where patients say, oh, I thought you were trying to cure this. Well, maybe we didn't communicate well. Maybe we said it's metastatic and assumed that they know that metastatic lung cancer is incurable because I know that. But they may not have known that. They might have heard me say, oh, the last patient I gave this chemo to, the lung mass went from this big to that big. They go, oh, that sounds like you're on the road to curing that patient. What will the cost of the proposed therapy be? And cost is not just in money, but it's in time, side effects, and quality of life. How many times do patients have one idea about what the cost is going to be? And they say, oh, that sounds good, doc. And then they find out they have to come to a clinic once a week and they can't do it. So initiating life-changing conversations without being aware of the patient's preconceptions is hazardous, isn't it? You start talking about this breast cancer or that this is therapy designed just to add a few months to your life but not cure you, and that this treatment you're going to have to spend the next 6 weeks in the hospital, and they had not anticipated that, it's not going to go well. The other big problem that the Spikes protocol will help you avoid is defensive clarification. What happens when a patient says, I went through all this chemotherapy, Dr. Marion, it made my hair fall out, made me sick as a dog, I had to be in the hospital with infections, and you're telling me it didn't cure my cancer? This was supposed to cure my cancer. Does it help if I say, I never promised that the therapy you received would be curative. What I said is it's going to give you your best chance for cure, but I never promised it would be curative. Nothing's 100%. Is that going to make her feel better, or she's going to say, oh, thank you, Dr. Marion? That clarifies that. Or a dialysis patient. I never said your dialysis would be temporary. What I said was that some patients recover renal function and come off dialysis. I never said you would. Dr. Blondin, is that going to make that patient feel better? Probably not. I never said that the antibiotics for your endocarditis would be completed in a week. We never even discussed the duration of therapy. Why are you so upset? Well, you didn't discuss it. They didn't know they needed 6 weeks of IV antibiotics and either being in the hospital or in an LTAC or have a PICC line at home if they can afford it. Okay, so getting defensive only escalates things. How often have you ever seen responses soothe those heightened emotions? They don't. And yet we keep doing it. We keep getting in these arguments with our patients. So to gain their confidence, we have to learn the skills to navigate these difficult conversations. And the good news are the skills can be learned. And that's called delivering bad news in a better way. This obviously is not a good way to deliver bad news. But you'll hear doctors kind of talk like that. We kind of really do sometimes. One of the people that I had the fortune of training under recently died, Dr. Buckman, and he's got this book on mastering difficult conversations. He said an expert in breaking bad news is not someone who gets it right every time. He or she is merely someone who gets it wrong less often and is less flustered when things don't go smoothly. I don't get it right every time. I've had my share of problems, but I probably have fewer conflicts than somebody else who doesn't practice this. And I don't go home as flustered. I go home saying, what worked, what didn't work, what can I do better next time? So to learn to break bad news, it's like everything. You have to have a stepwise plan, and the stepwise plan means that you've done, before you move on to one step, you have to complete the other step successfully. You don't do an LP by sticking the needle in and then getting the patient to sign the informed consent and then cleaning it off with betadine and then putting on the fenestrated drape. Those were all appropriate steps, but they were out of order. So you have to do them one step at a time. And Robert Buckman and Walter Bale, who was at our ethics conference 2 years ago, the reason I keep plugging our ethics conference, we have another one coming up in December. They put together a protocol called SPIKES with a little mnemonic. It stands for setup, perception, invitation, knowledge, empathy and emotion, strategy, and summary. So they say your job is first to gather the information, provide unambiguous information, support the patient, and come up with a plan of care. The setup is pretty important. When you know you're going to go tell somebody something they don't want to hear, you've got to acknowledge that to yourself. And you need to do a few things. You need to rehearse. You need to say, who is this patient I'm talking to? Oh, this is the patient who gets really angry. This is a man who gets up and starts cussing. This is a guy who's going to pull out his own IV and say, well, I'm just going home then. I need to know who I'm talking to. Or this is a patient who doesn't say anything. I need to know who I'm going to talk to. I'd like to have as much privacy as possible. If the patient has a roommate who's there for something non-critical and his kids are all in the room with him jumping on the bed, that's probably not the place to have a serious conversation. I want to involve significant others if significant others are always involved. I always want to sit down. What does it mean when I'm standing? You're half naked in a gown and I'm fully clothed and I'm standing. What does that create? A power differential, doesn't it? I'm the boss and you're the one who has to listen to what I have to say. We know that if I sit down, I lean in and look at you, it says we're on the same level and patients are more likely to talk to you than if you're standing towering over them. So always make sure that you find a chair. If you know you're going to have bad news, walk by the room. If there's not a chair there, you know we do it all the time. We go get a chair from the nurse station and bring it in because we know this is something we need to be sitting down. You want to connect with eye contact and gentle touch if gentle touch is appropriate. And you want to manage your time constraints. So I would hand my beeper to the resident and say, unless it's an absolute emergency, tell them I'll call them back. You don't want to say to somebody, I got really bad news to tell you, and then walk out of the room because your beeper went off. Now, we talked about understanding the patient's perception of what's going on, that we said that was one of your potholes, starting to talk without knowing what the patient came prepared to hear. So this is one of those ask, tell, ask moments. Before you start talking, ask their understanding. Why did Dr. Levine have you come see me? What was Dr. Blondin thinking of when she got the scan? Tell me what you understand. Don't use closed-ended questions. Don't say, did Dr. Chu tell you that that breast mass is probably a cancer? Because now you've defeated the point of the open-ended question. You've told her what it is. So say, what did Dr. Chu tell you that likely was in your breast and why he wanted you to see me? And if she says, oh, he thought it's maybe just a little cyst or infection, you know you got some work to do because Chu told you this is a really angry cancer. That allows you to correct for misinformation or preconceptions. It allows you to detect denial. Some patients, that is their coping mechanism, and you don't have any right to crash it down right away. and you have to tailor your communication to their understanding. So the way you do check for a patient's perception is, I would say, so what have the other doctors told you about your situation? Oh, they think it's probably just some little cyst because my mom had a bunch of cysts. Okay, now you're thinking this is cancer, but that's not where she's at. So before you start talking cancer, you need to get her on the page with you. And you're going to have the amygdala to deal with. Or you might say to her, so tell me, what are you most concerned? I've told you I want to get a CAT scan. What are you most concerned about? She might say, well, I'm worried that you think this is cancer and it's spread. Okay, that tells you she kind of understands. Or can you tell me your understanding of what's going on? So the important thing is, before you start talking, you better know what your patient's thinking. And then the I is very important. That's asking for invitation. In a way, it's a warning shot over the bow. If I say to you, what did your doctors tell you? And you said, oh, they said it's likely a breast cyst. And if I say to you, may I tell you what I'm concerned about? Isn't that a little bit of a warning shot? Because if I also thought it was a cyst and you said, oh, my doctor thinks it's a cyst, I'd say, yeah, that's right. But if I say, may I tell you what I'm thinking about, it's your first warning shot that something different and unsettling may be headed their way. So that's your invitation. They may say to you, I don't want to hear. Patients have said that to me, not many, but I'll say, can I tell you what I'm concerned about? And they go, no, I don't want to hear. And you know what? I have to be respectful of that and say, well, is there a time we can meet, or is there other people in your family or friends who you want to have present, because we do have some important things to talk about, but we don't have to talk about it right now. Should I come back later? Yeah, can you come back when I can have my husband and son here? Okay. But you see, if I don't do this, if I don't ask the perception and the invitation, I just start talking and I blow the patient out of the water. So I might say, may I tell you what I'm most concerned about? Again, that is a warning shot. I have some important information I need to share with you. Would that be okay? And then you give your next warning shot. You say, unfortunately, I've got some bad news we need to discuss. Or I wish that I had better news for you. You might notice that I've highlighted wish in yellow. Lots of studies have shown, and they're interesting psychological studies, that wish statements are better coming from a doctor than sorry statements. We've all said things like, I'm sorry to tell you. Why do you think a sorry statement doesn't go over as well? When do you normally say, I'm sorry? I can think of 2 occasions. You did something wrong, and what's the other? Pity. I'm sorry to hear your dog died. So I'm either apologizing for something I did wrong, or I'm showing pity. And if I'm the person who's receiving the bad news, I don't want to hear you did something wrong, and I don't want to hear that you're pitying me. That makes it even worse. So you got to kind of practice not saying, I'm sorry to tell you. It's much more powerful to say, I wished I had better news. Lots of studies have shown that patients react much better to that statement. I wished I had better news for you. That's your second warning shot. The first was, may I tell you what I'm concerned about? And your second is, I wished I had better news for you. And then you want to give the knowledge. You want to tell them what you found. I am really concerned that this is breast cancer, not just an infection, not just a skin infection on your breast. You want to avoid statements that makes the patient feel isolated. There may not be anything more I can do for their disease, but there's always something I can do for them. So never say to a patient, there's nothing more I can do for you. You might have to say, I am running out of bullets, or I'm out of bullets for the treatment of your cancer, or the treatment of your HIV, or the treatment of your heart failure. But I've got some ideas that can make your life a little bit better. We need to set some goals. Tell me what you're interested in with the time you have left. You want to give small packets of information and summarize it frequently. It's called chunk and check. Because like we said, you want to be sure, the reason you're doing this is to make sure that the frontal lobe is in control. Because if the amygdala is still in control, they're not getting it. So if I say to the patient, okay, now I want to recap, can you kind of tell me what we've talked about? Yeah, you told me that the CAT scan showed this and you think it's cancer. Okay, I can go on to the next. If she goes, I don't know, doc, you mentioned something about the CAT scan, I don't know what it showed, then you kind of know you got to back up a little bit. Don't go to your next step. And then you want to use English, not medical jargon. The word metastasize, I think in that study I mentioned in the New England Journal about the patients with lung cancer and colon, the doctors passed a lie detector test. They'd say, oh, we told the patient it was incurable. The patient say, no, he didn't. I bet you a lot of it was the doctor used the word, you have metastatic lung cancer, and assumed the patient knew what that meant. Okay? They may not know what metastatic means. So use the word your cancer has spread to your brain, not it's metastasized. And then you have to deal with your emotions and empathy. Even though you've given the warning shots, keep in mind the patients may show shock, disbelief, crying, anger, denial, even silence. Some people just sit there staring off into space. Each one of those is going to require an empathic response by using the NURSE protocol. Especially if the patient's sitting there silent, I would say, can you tell me a little bit about what's going on in your head right now? So you have to go in knowing you're going to tell somebody some life-altering information. It's going to change their life, perhaps forever. It's not going to be good. You need to anticipate a tsunami. So you can't control the wave. The best you can do is anticipate it, know it's coming, and then attempt to ride it successfully without wiping out. But you have to, it's a cognizant decision you make. So to generate the empathic response, you want to look for any emotion, you want to identify it, you want to kind of link that to a reason. You want to let the patient know that you've witnessed the emotion and you've connected. And then you want to normalize and validate it. Now, how do you let them know you're aware of their emotion? We talked about the naming, but there are lots of other things other than I can see this is frustrating for you. I can see this is upsetting you. I can tell you weren't expecting this. This must be very frustrating for you. It must make you angry that the treatment hasn't worked the way we wanted it to. This is even frustrating when we walk in the room and we know we're running 2 hours behind, and we walk in and the patient's kind of walking back and forth and they look at you like, they're mad because they've got to pick up their kid at school or they took off work. They're mad you're running 2 hours behind. Does it make them feel better if you say, oh, I'm really sorry, but the last 3 patients are really complicated? Is that going to make your patient feel better? Does it make you feel better when you're waiting all day on a Saturday for the cable guy to come and he shows up 4 hours later and you've wasted, and he says, oh, the last house we really had a lot of problems. Do you say, oh, that makes everything better? No. How about this? Instead of telling the patient why you're late, say, I can understand this must be really frustrating for you because I'll bet you've got 100 other things you needed to do today. Let's try and get to things. Then you've at least let them, before they strike out at you in anger, saying, Dr. Marion, my time's precious too. The second you see that they're a little upset and you know you're running 2 hours late, say, this must be really frustrating for you. Now, normalizing and validating. Some people think that means that you're like the woman who said to me, you made my hair fall out and you took off my breast and now you're telling my cancer came back. I thought that treatment was going to cure my cancer. We kind of get into that cover your ass philosophy that I have to defend myself and say, oh, I never promised. What I said was the chemotherapy would take your risk of an 80% relapse down to a 30% relapse. Unfortunately, you're in that 30% that's still relapsed. That's not going to make her feel better. And you don't want to say, yeah, you're right, I screwed up, but you can say these kinds of things. It's okay for you to feel that way, because it is okay. Because in her mind, she gave up a breast, her hair fell out, she vomited, she canceled her summer vacation so she could come in every 2 weeks for her treatment, it is okay for her to be pissed that the treatment didn't work. So you can say, I understand that you must be angry. You are correct to think that way. You know what? If I took a treatment that was so strong that it made all my hair fall out, I would have imagined it would have killed my silly cancer too. Your hopes weren't unreasonable. You were hoping for a cure. That was a reasonable thing to hope for. We were all hoping for a better response. See, that lets the patient know you're on their side. Anything else you say is going to be me versus you. The second you start defending yourself, it doesn't help. So you need to normalize and validate and say it's okay to feel this way. Now, generating empathic responses, there's one last thing you need to know. You're another person and you have your own amygdala, don't you? It's not just the patient's amygdala. So this is not the time for defensive clarification. It's not the time to discuss options like our fellow did at the beginning of the talk. And this is definitely not the time to allow your amygdala to hijack your frontal lobe. So let's look at this. Here's our patient and here's our physician. And you just got done telling the patient that their cancer came back. So guess what? There may be anger there, frustration, and fear, and so bam, her amygdala explodes. And you're the physician watching all of this, and you're seeing her getting angry, and now you start feeling defensive, you're anxious. You might even feel guilty because you had to decide, do I give this chemo or that chemo, or do I do this or I do that, pick gentamicin versus vancomycin. You pick something that didn't work out, so there may even be guilt. So guess what? Your amygdala is exploding. And what happens when you've got two people with runaway amygdalas and not a frontal lobe in the room? That's fertile for conflict. So again, that's part of your understanding, is to know you have an amygdala too. And don't respond to a patient in a way that's going to escalate it. And that's where using those kind of statements like, I understand this is difficult for you. I understand that you're upset. Those things also keep you from exploding. And you don't want to say stupid things like, well, it could be worse. You know, you've only got one met in your brain. You could have 5. That's not going to make her feel better. Or I've seen, believe it or not, I've seen doctors say, why, you know, you're acting like you're going to be the first person on earth to die. Everybody dies. I'm sorry I can't cure you, but everybody dies. That's not going to make them feel better. And again, you never say nothing more can be done, because there's always something you can do for the patient. And what about I know how you feel? Does that sound like an empathic statement? It kind of does. But an empathic statement would be, I can understand how difficult this is for you, but never say those words in that order. Because if you do, what's the patient going to do? You don't know how I feel. You're going home tonight to eat dinner with your family. I got to go home and tell my family I got cancer. Don't tell me you know how I feel. So don't use those words. That's not an empathic statement. It sounds like, almost sounds like one, but an empathic statement would be, I can sense that this is upsetting you, or I can only imagine how bad you must feel. But don't say, I know how you feel. And then you do your strategy and summary, you kind of recap everything. So in conclusion, watching a master clinician in action may leave you believing that seamless, fluid, and responsive communication is easy. Or some people say either you got it or you don't. It's kind of like being hot on a Saturday night walking into a bar, right? There's nothing I can do. I cannot study. I cannot practice. I walk into a bar on a Saturday night, no girl's going to look around and say, oh, that guy's hot. It just ain't going to happen. I can't study for that, okay? So that is true. Being hot on a Saturday night in a bar, you can't practice for. But learning how to deliver bad news and communicate with your patients, you can learn. So don't say, oh, that person's got the gift of gab. He knows how to. These are things, like I said, I think I do a relatively good job, but I'm learning still. There's not a night that I don't go home and say I could have handled that better. But it makes me a little bit better each time. So instead of just saying I can't be like that, start practicing it. So take the spikes protocol and start using when you have to break up with a significant other. Say, honey, You know I invited you out to dinner tonight. Oh yes, because we've been fighting, you want to kiss and make up. Well, may I tell you why I invited you to dinner? Okay, and then so practice it in other situations, not just in the taking care of your patients. In fact, master clinicians are actively collecting data from their patients and carefully choosing tools from their communication toolbox. You got lots of tools in your toolbox. And they're constantly readjusting their gestures and words to improve their connection. What if this talk meant anything to you, it means I don't want you to ever have to say what our next cartoon doctor is saying. Any questions? Is this helpful, do you think, a little bit? Well, I hope so. It helps me. It helps me. I'm not frightened when I have to walk in and tell somebody stuff they don't want to hear, because I've got a toolkit, and I know how to use it the best I can. So have your toolkit, and I promise you, going into the room and having these difficult conversations with the patient and the whole room full of family members will go much smoother. So thank you very much.